Jessica, I'm going to have you give us some of your take-home tips for the community, and then for Marla, Bill, and David, maybe some lasting impressions that you have or any topics that you'd want to address. So Jessica, what are you telling your community GI about IBD?
Yeah, so I think sort of really putting together everything we've been discussing today, often when I'm talking to my community colleagues, again, it's really going back to basics, confirming the diagnosis when you have a patient in front of you, really using a multimodal approach to really understand your patient's risk factors, how sick your patient is, and really are they at risk for bad outcomes, to really try to get them on the appropriate therapy up front. And again, really stressing that we're not doing this everyone gets mesalamine upfront model anymore, and really trying to use personalized risk factors and risk assessments to get patients on appropriate therapy upfront. Again, thinking through patients' individual risk factors, their comorbidities, and using those together to get the patient on the right therapy. And again, really stressing this treat to target model, that when you are starting a therapy, you really have to have goals set for both you and the patient that you need to be meeting. And if you're not, you need to understand why you're not meeting those and make changes so that you are. And so that's something I often talk about with my community colleagues. And also, again, sort of thinking through a lot of what David was just discussing as well. How are you going to get the therapy? Thinking through all the factors, whether it's at mode of administration, getting your insurance companies on board, and thinking through those processes. I know we're very fortunate at tertiary care centers. We have a lot of support to do some of these things, and some of our community colleagues don't necessarily have that. So upfront, thinking through what are the processes for infusion centers, for getting injectables, what specialty pharmacies are you working with, sort of familiarizing yourself with those processes upfront, I think will save a lot of time once you're sort of in the thick of it with patients. And then always, if you're feeling overwhelmed or unsure, feel free to reach out and refer to your colleagues at tertiary care centers who are very happy to co-manage patients with you and provide advice. I think we fully recognize that this field is getting increasingly more complicated. We have a lot more choices, which we're happy about, but we understand that if you're not doing just solely IBD care, it can feel a bit overwhelming. And so to really utilize us and our colleagues as resources to really help provide the best patient care possible.
Great. So Dr. Allegretti, thank you for that wonderful overview. I think that kind of summarized everything we had talked about. And then, I want to thank again all of you for your information. But before we do conclude, I want to get some final take-home thoughts from each of you. Maybe Bill, your take-home thoughts?
I think this is a really exciting time for patients, and as Jessica just said, it can be a little daunting for practitioners, but it's also an exciting time for practitioners. We have a lot of therapeutic choices now, and over the next few years, we're going to have a lot more. The evolution of use of biomarkers in clinical practice is a big deal, evolving thinking about treating to target. We didn't talk much today about precision medicine in the sense of picking drugs based on biology, but I do think that's going to come to the forefront in the next 5 years as well. And, then telemedicine and team care are huge issues. And, we probably won't recognize for the better what IBD care will look like, in the 5 to 10 year time horizon. It's going to be so much better as all this stuff comes together. So I think it's a really gratifying and exciting time to be in taking care of these patients.
I agree. And I think to pick up on your telemedicine and virtual care, that will bundle all the biomarkers and the treatment and the outcomes. It's interesting, the virtual care, the telemedicine care probably will also evolve into e-consults, as I think many of us are starting to do, and even e-second opinions where with our physicians across the country. So Jessica, you mentioned bringing groups together from remote areas. I think that's going to be probably in the next 2 years. I would say before all of this, I would say 10 years, but I think we're going to be closer. So Dr.
I'm smiling because I just saw a patient that you did an e-consult on, and he came back and said, well, he didn't tell me anything that you didn't already tell me, so we're good to go.
Yeah, he came to Cleveland Clinic, and I looked at who took care of you before? Bill Shamwar. And I'm like, okay. Not sure there's going to be much there. All right, Dr. Dubinsky, what are your take-home points?
I mean, I think similarly as Bill alluded to, I think that as I noted before, although it can be daunting, I think with advances in technology and our ability to integrate genetics and biology into our practice, I think there's a rapid increase in technology and platforms that could help to bring precision medicine into the clinic for all patients, no matter where you're seen, no matter where you're diagnosed, what city, what state. And I think the fact that there has been a clear understanding on the role of team and tech, as Bill was noting as well, that we are going to get better at how we deliver care. And I think that means that not only are treatments expanding, the way we deliver care is going to improve. It's a win-win for patients and for every stakeholder, those who seek care, deliver it, pay for it. I think everyone's going to benefit from these advances in the field of IBD.
Great. Thank you, Marla. And then David, I'll turn it to you to give the final word.
I think what we've heard today is really a variety of concepts that have emerged in our management of IBD, and my colleagues have said it very well. So I don't want to repeat all of that, except to say that we really are in an era of disease modification now in IBD, where we need to be focused not just on effective therapy in the short term, but actually changing outcomes in the longer term. And I think that every patient with IBD deserves a team approach to their management and a proactive assessment and plan. So I'm looking forward to that, and I'm sure that our patients will benefit from it.
And the team approach, interestingly, as probably all of you are doing too in the virtual world, has actually become somewhat easier and different, either as disconnected visits for the patient over a period of a week or two, which sometimes they like little breaks between rather than all at once, or sequential visits or in the same room visits. So I think it's really an interesting time. With that, I wanted to conclude today, and I wanted to thank my colleagues, Dr. Allegretti, Dr. Dubinsky, Dr. Sanborn, and Dr. Rubin. Thank you again, and to our viewing audience, we hope you found the HCP Live Peer Exchange discussion to be useful and informative.